Welcome back to another episode of Gender Queries. My name's AJ, and I use he/they pronouns.
I'm Jess, and I use they and she pronouns.
And I'm Sam, and I use they/them pronouns.
Today we're going to take a tour of the organ systems. We're going to see what the research says about physical health in the trans population, whether that's a result of the social determinants of health and the things that those influence, like exercise and diet, hormone therapy, behaviors like binding, chronic stress, the allostatic load, or, most likely, all of the above. Just a heads up, this episode involves a lot of medical terminology and acronyms. There will be a file that you can find through the show notes where you can find the meaning of the acronyms used. And another heads up, most of this research is done on binary trans people, which means we don't have a lot of information about how heart health might be affected in a non-binary person who's taking a microdose of estradiol, for example. On that note, we'll start at the heart. We've talked about exercise, we've talked about diet. We know that both of those things can affect heart health. And knowing that trans and gender diverse people on average get less exercise and eat less healthy food, we have to assume that their heart health will suffer.
Mm-hmm.
But gender-affirming care itself, specifically hormone therapy, how does that impact the heart? There was a study in 2019 by Al-Zarani and colleagues, a cross-sectional study with a cohort of people that were around the age of 50. And for trans women, the odds of MI were increased compared to cis women, but not compared to cis men. And for trans men, the odds of an MI were over 4-fold higher than cis women and over 2-fold higher than cis men. In the study, they adjusted for age, diabetes, chronic kidney disease, smoking status, hypertension, hypercholesterolemia, and exercise.
So, yeah.
Wow.
What did they not adjust for?
Economic status.
Yeah.
Social determinants of health.
Yeah. Interesting.
It still shows that there is a higher risk, probably influenced by social stressors, health disparity, socioeconomic status, substance use. All those things would predispose someone to cardiovascular disease. And we know that trans people are affected by minority stress.
Stressors are huge on health. And I wonder, how long before getting hormone therapy were they living in a state of dysphoria?
Right, and they grew up in a time when it was less accepted. So they would have had that increased stress if they hadn't come out, and then stress if they had come out and were getting discriminated against.
Yeah.
So it'll be interesting to see how that data pans out as our generation ages. Will it be a little bit better? Obviously, there's still a lot of minority stress, and there's still discrimination. And it definitely depends a lot on where you live, etc. But still is definitely different compared to that generation.
Specifically looking at estrogen therapy, there's a lot of research on estrogen and venous thromboembolism. It's done on postmenopausal patients, not in the trans population specifically. The extent of the risk is going to depend on things like the type of estrogen, the dosage, and the route of administration. Something like bioidentical transdermal estradiol is associated with a lower risk of VTE compared to something like oral ethinyl estradiol, which is actually avoided now for gender-affirming hormone therapy because it has a known risk. If you look at population-level data, the rate of VTE and other acute cardiovascular events is higher in the trans population that are taking estrogen compared to cisgender controls. We always say the same thing, but there needs to be more research done to really fully understand what's going on. For the time being, it's just kind of emphasizing the importance of monitoring and counseling on things that you can change, modifiable risk factors like smoking and obesity. We're looking at this and saying, well, you have the potential to have thrombotic complications if you're taking this medication. It definitely does not mean that you shouldn't prescribe it. There was a study in 2014 by Ashman and colleagues that looked at a population of people who didn't have access to gender-affirming hormone therapy, and some of these people resorted to taking really high doses of oral contraceptives in an effort to achieve feminizing effects, and that carries a high risk of VTE.
I think it's an important thing to think about in terms of harm reduction.
Looking at testosterone, in 2010, Fernandez-Balcells and colleagues showed that testosterone therapy is associated with a rise in inflammatory markers, which can promote clotting and vasoconstriction. There were increases in thromboxane, hematocrit, hemoglobin. Those aren't typical clinical markers, but they do indicate inflammation. In 2012, a study by Dubois showed that trans men who reported higher levels of stress, specifically they noted the stress of passing, had increased CRP levels. So these are multifactorial changes for which the clinical significance is not really well understood.
So if you're a doctor and you're seeing a trans patient and you're trying to figure out what to do in terms of cardiovascular risk prevention, how should you calculate that risk for them?
Generally, there are not official guidelines telling you what to do. And in terms of cardiovascular risk, UCSF states that depending on the age at which hormones are started and the length of exposure, providers might choose to use the calculator for their sex assigned at birth, a firm gender, or an average of the two. So basically it's going to come down to some clinical judgment.
Dr. Heather Cockwell gave an example of how she approaches this in practice.
I'm one of the 4 gynecologic, reproductive endocrinology, and infertility specialists in the province. I am one of the 2 physicians who runs the gender affirmation clinic at the IWK. When you Framingham risk score somebody who is a cisgendered individual with ovaries, they get, well, they lose points for being that individual with ovaries, right? So my trans guy doesn't lose those points because he's on testosterone. When I finish my scoring system, I don't compare it to the one for people who have ovaries. I compare it to the one for people who have testes. And then based on that, I can sort of see, okay, is this individual at risk? Because people with testes tend to be at higher risk, so my trans guy is going to be at higher risk too. He's the guy who would need to follow his cholesterols in, right, a little bit more closely, and maybe react to them sooner. Whereas if you had a cisgendered woman with the same cholesterol level, you might not react to it the same way. I think more in terms of what hormones are in their body than what gametes are they carrying with them. And so I have that kind of question in my head first.
There are a few recent papers that are looking at EKG changes in trans people taking gender-affirming hormone therapy. They found that even after a few months, someone's EKG will shift towards patterns that are associated with estrogen or testosterone-dominant physiology. For example, a trans woman who is androgen suppressed and on estrogen, their EKG would fit into the range of normal for a cis woman. This is thought to be driven by testosterone, so either the addition of testosterone or the suppression of testosterone. They've shown that testosterone shortens a QTC and androgen suppression prolongs QTC. The clinical significance of this is unknown, but they haven't found any harm associated with these changes. But it's good to know for EKG interpretation and theoretically could be relevant for someone taking other QT prolonging medications. I was looking at the health report card at the mortality due to respiratory diseases, and the Atlantic provinces score a grade of C. Canada overall scored a B. We do have higher rates of smoking here in the Atlantic provinces, which is the major contributor to respiratory disease. Smalley and colleagues in 2016 showed that trans individuals are more likely to smoke cigarettes than cisgendered individuals, but within these groups, the rates also vary by sexual orientation, with bisexual trans people smoking the most and also smoking the most marijuana. A study out of Australia in 2023, Bailey and colleagues, suggested that the substance use in the trans population is in part the coping mechanism for things like sleep difficulties, depression, anxiety, cisnormativity, and also they mentioned specifically wait times to access gender-affirming care.
That doesn't surprise me.
We're not going to get into the details of binding, but there was a small study done by Voss and colleagues in 2024 that looked at a group of 18 teenagers that were 13 to 17 years old, and half of the participants reported binding while exercising. However, when they did exercise testing and looked at PFTs, binding versus not binding, there weren't actually any changes in their exercise capacity. They did have an increase in pain, overheating, poor posture, and shortness of breath.
I'm Meaghan Ray Peters. I'm a physiotherapist and a PhD student at the University of Alberta in Edmonton. I am also non-binary and use they, them pronouns. And I've been studying chest binding for the last 4 years. And before that, had personal experience and community experience, secondhand experience. So it was in my mind for a long time before coming back to do research on it. In the last 2-3 years, the majority of the chest binding research has been on lung function, and they've looked at pulmonary function tests compared to people who don't bind, and they've looked at comparing binder on versus binder off. They've looked at VO2 max with the binder on versus the binder off. And almost all of them have shown minor differences in different ways, depending on the study and the population, but there's statistical significance, but not clinical significance. There's some symptoms of restriction, and it tends to match the restrictive lung disease pattern of restriction, but it doesn't go beyond normal limits. So the amount of shortness of breath and how common that is not explained by changes in lung function, either acutely while the binder's on or chronically.
Is it thought that there might be some kind of more permanent remodeling that happens if someone is binding over years?
One of the more common reported symptoms that people will present to healthcare providers with is spine and rib changes. The most common one is stiffness. They also describe it as hunched shoulders, rounded spine, that kind of thing, and flaring of the bottom ribs, because a lot of people wear the half tank top style where the compression comes down to about rib 10 and then rib 11, 12. That's where you're getting all your lung expansion from. So they end up over time flaring out. That's my thinking around it anyway. And so my guess in terms of the restrictive lung pattern is that it's more of stiffness related. Yes, you have the compression of the binder, but you also have the stiffness of the structures underneath. What's interesting is that when you compare the amount of shortness of breath that people have with the binder on versus the binder off, it goes away almost entirely. So it's very much related to the compression of the material, but there's still some that is still present with the binder off. Pain, on the other hand, is much more common and much stronger, much more intense, even when they remove the binder. It does improve a bit, but not as much as you would think. It doesn't go away. So binding symptoms can continue when they take the binder off. So there's something mechanically or physiologically going on in terms of the rib and spine structure that is causing that pain to persist and causing the mechanics of the back, shoulders, and ribs to change somehow. So that's what I'm looking at in my PhD research and some of the functional stuff. Can you still lift overhead as well with a binder on versus a binder off? That kind of thing. So
I was curious about whether binding could cause diaphragm fatigue, which might contribute to reported dyspnea. And Meaghan Ray explained that nobody has specifically studied whether binding causes diaphragm fatigue or weakness, so from a research perspective, it's unknown. However, binding restricts ribcage expansion, mainly limiting the lateral and AP expansion of the chest, which is the most efficient and functionally adaptable breathing pattern. Because the ribs can't expand normally, the body compensates by relying on more apical breathing, which uses accessory muscles and increases the work of breathing. And also diaphragmatic breathing, which is probably predominant, but it can become harder, especially when seated, because the diaphragm faces more resistance. And the breathing pattern tends to be slower and less flexible when oxygen demands increase, like during exercise. So, while there's no direct evidence yet, binding does cause someone to breathe differently, either by working the diaphragm harder or using accessory muscles. So the increased effort and altered breathing mechanics could potentially lead to diaphragm fatigue or that feeling of dyspnea, especially when breathing demands go up. The hormones that are used for gender-affirming hormone therapy, including those used to delay puberty, are hormones that in their natural form or in their therapeutic form have a role in bone health. In Canada, there's a lot of research looking at osteoporosis and fracture rates, but it doesn't usually include transgender people. Because these therapies play a role in bone health, it's really important for us to understand how trans and gender diverse people will be affected.
More people are accessing gender-affirming care, and so we're going to have a more aging population having been on these hormones, and so
it's important to be able to assess their risk and then also know how to manage it. Why is it so important to reduce fracture risk?
Things like hip fractures are major predictors of morbidity and mortality.
Fragility fractures can result in devastating loss of independence and also death, so it is an important topic. There are a lot of risk factors for osteoporosis. Some of the non-modifiable ones include medications, family history, hormones, and being female. And we can assume that these risks were derived from data on people who were assigned female at birth and have not taken gender-affirming hormone therapy. There are some modifiable risk factors like diets that are low in calcium, vitamin D, and other nutrients, low body weight, physical inactivity, smoking, and excessive alcohol use. And We've already talked about how the trans and gender diverse population is affected by social determinants of health on a population level.
How come it seems to affect people in an estrogen-dominant milieu more? How come their bones seem to be more vulnerable? Is there one sex hormone that's more important for bone growth?
We know that both estrogen and testosterone are important for bone formation and turnover during puberty and in adulthood. Cis males without estrogen, so like someone who has a mutation in the estrogen receptor, will have a low bone mass despite having adequate testosterone. And then males and females in hypogonadal states have been shown to have higher rates of osteoporosis. Over time, with age, sex hormones do decline, but the decline is more profound in people assigned female at birth, and that's why the risk increases. The International Society for Clinical Densitometry, as of 2019, states that as long as the trans or gender diverse individual is on standard gender-affirming hormone therapy, their bone mineral density should remain stable to increasing. So there's no indication to monitor for bone loss or osteoporosis strictly on the basis of being on hormone therapy or being trans or gender diverse. If there are substantial periods of hypogonadism over a year, then you would consider doing a baseline measurement. They state that there is no evidence that trans and gender diverse people have a higher fracture risk compared to cis people, and there's no evidence that bone mineral density predicts fracture risk less well than in the cisgender population. In terms of the Z-score, you can calculate using the reference data for the affirmed gender if the person is taking gender-affirming hormone therapy.
Our peak bone building years are when we're like in our teen years leading up to about age 25. In those individuals who are trans men, their bones are going to be fantastic. But the concern is the opposite in the trans women, because I'm taking away their testosterone, right? And then I'm giving them estrogen. I'm essentially making a trans woman potentially at risk of osteopenia in the future. The puberty blockers basically shut down all hormones, right? So those peak bone building years when you need your hormones to build your bones, there is a concern with osteopenia in that way. And there's a concern with them in general. Like if you take anybody and give them a GnRH agonist, that's what we use for puberty blocking, those people have a risk of osteopenia. There's a sort of unknown of taking a 8-year-old and putting them on GnRH agonist when they're supposed to be building their bones. And so all you can really say is, drink a lot of calcium, eat a lot of cheese, that sort of thing. It's not very satisfying. So we do actually monitor their bone densities. It's one of the few indications for doing bone densities less than age 50. And part of what we struggle with that is that we don't have a lot of norms for that. Like they haven't really done the tables for people less than 50 who have low hormone levels or what have you.
I'm Arati Mokashi. I'm a pediatric endocrinologist at the IWK Health Center. I use she, her pronouns. I'm the medical director for the gender clinic in pediatric endocrinology. Transgender girls were found to have lower bone density even prior to starting Lupron. They surmised that this might be related to the fact that transgender kids in general have lower levels of physical activity, in part because if you're dysphoric, first of all, you may not be as active in sports, but also, if you have to go on a boys' team, you identify as a girl, that can also make things challenging. So it's not just about the puberty blockers, but we do know that there's a direct association between having low sex steroids and lower bone mineral accrual.
When it comes to vitamin D, which is very important for bone health, Chen and colleagues in 2019 showed that gender-affirming hormone therapy doesn't interfere with the assessment of vitamin D status. And the thought is that because vitamin D binding protein is influenced by sex steroids, that hormone therapy might mean that the measurements of vitamin D don't actually represent the total 25-hydroxyvitamin D. But in this study, they showed that the measurements are representative, which makes things simple.
Type 2 diabetes is very common in Atlantic Canada. Research by Islam and colleagues showed that even though trans feminine people are more likely to develop type 2 diabetes, this doesn't appear to be attributable to gender-affirming hormone therapy. There's also no evidence that testosterone therapy increases the risk of diabetes in transmasculine people. There was another 2021 paper that really nicely summarizes the evidence-based recommendations for managing diabetes in the trans population.
The authors, Moverly and colleagues, concluded that because estrogen can increase your risk of hyperglycemia, you want to increase your monitoring and titrate insulin accordingly. in terms of lipids, you want to just do those as per the guidelines. And for testosterone therapy, that can increase your insulin sensitivity. So you want to monitor for hypoglycemia and consider decreasing insulin. With testosterone, because there's an increased LDL and triglyceride level, they emphasize that you closely monitor for dyslipidemia. And for patients with PCOS, who would be at an increased risk of developing insulin resistance from the PCOS, you want to monitor closely because in the context of testosterone, the risk is actually not well understood at this point. For adolescents who are taking GnRH agonist therapy, they also recommend that you check for diabetes at baseline and then periodically monitor thereafter. I just wanted to briefly bring up CBCs. There was a study done by Green in 2019, and they looked at red cell count, white cells, and platelets, concentrations of hemoglobin, hematocrit. They looked at the MCV and the MCHC. They concluded that regardless of serum hormone concentration, individuals that were prescribed testosterone or estrogen had parameters that were not clinically different from cisgender males and females, respectively.
So you're saying that if you were a trans man taking testosterone, it would be acceptable to use the cis men reference ranges?
Yeah, in terms of those specific parameters.
Something else you might see on lab work, for individuals who bind, they may have an increase in their prolactin levels due to the compression on their chest. This is not something that's typically monitored in adults, but you might see it monitored in pediatrics.
My name is Ken Mullock. My pronouns are he, him, and I'm a registered dietitian in Regina, Saskatchewan. I work in the area of chronic disease prevention and management. I think it's important to acknowledge that among the trans community, we do see higher rates of diabetes, cardiovascular disease, chronic health conditions, even cancers and that sort of thing. But we need to understand that these aren't inherent to someone being trans, but more closely related to the ongoing oppression of trans people in our healthcare system and trans people avoiding health services, being denied care, feeling uncomfortable seeing healthcare providers. That's why it's so important to create a space where our trans patients are celebrated and included, appreciated, and able to access services where they feel completely accepted and acknowledged. And I think there's benefit to a trans person seeking healthcare beyond just being able to access hormones and surgeries and that sort of thing. So when a trans person is seeing a doctor, for example, to get hormones, when they're coming back to get their hormone levels monitored or refills, we can use that as an opportunity to monitor other things in their health, prevent or manage chronic diseases, and that sort of thing. But I think it's also important that we don't medicalize or pathologize someone's transness too much and not require someone to be completely healthy and well in order to pursue transition or to go further in their transition.
My name is Jocelyn Adams. Pronouns are she, her, and I'm the Executive Director of Gender-Affirming Care Prince Edward Island and one of the co-founders of Gender-Affirming Care Prince Edward Island. Our tagline is, trans health doesn't end with transition. The goal is not just gender-affirming care and transition. The goal is healthcare from now until the day you die, right? This is palliative care. This is hospice. This is home care. This is pregnancy. This is diabetes, heart disease, cancer. Like, this is everything. Everything we've never had to worry about before, because we were only worried about suicide and drug use and overdose and murder in some cases. Now we're like, oh, we get to die like everyone else, but no one's studied it. So now's the time to really start thinking about research into what some of these standards and policy sort of things should be as trans people age, because luckily we're going to live longer. And, you know, we're going to get to a ripe old age and things are going to fall apart, but our bodies are going to fall apart in very interesting ways that are not like cis bodies. I really want people to start thinking about that.
Thank you for listening to another episode of Gender Queries, and thank you to our guests for their stories and expertise. You can check out the show notes to find our transcript, sources, and resources recommended by our guests. You can contact us at genderqueriespod@gmail.com and find us on Instagram at genderqueriespod.